35-year-old woman is having breakfast, and just like that, suddenly she collapses at the table, slumped and difficult to rouse. By the end of this video, you'll know exactly where her lesion is and how to localize the multiple other signs and symptoms that this part of the brain controls. Welcome to the Spiral Neuroanatomy course. We draw a map of the nervous system, and with each pass we go deeper and deeper until you've mastered everything there is to know about neuroanatomy. But for this episode, everything you need is right here. So let's get started. We've spent the last episode moving down the map, just below the cortex into the internal capsule, and now we're going to take a step back to the structure sitting right behind it, the thalamus. So as always, please excuse my horrendous drawings. So the first thing to know is that the thalamus is the largest collection of nuclei in the entire nervous system. Nuclei just means cell body. It's huge, and there's two of them sitting on either side of the brain. So if I was to draw the brain in what we would call an axial view, so again, I'm cutting my head this way and looking down into the skull, into the brain itself, we'd do a dotted line down the middle. And around the edges is the cortex. So this is all our gyri around our edges. And let's just say this is left and this is right. Your thalamus sits deep within the brain in that kind of posterior aspect. So right about here. And there's one on either side. Now, the way I want you to think about the thalamus is as a relay station. Now, if you live in a big city, think of your busiest train station. Everything passes through it. Trains are coming in from every direction. They're coming in from the country. They're coming in from the city. People are changing lines. Signals being sent back and forth. Almost nothing in your brain reaches the cortex without first stopping at the thalamus. And that is the key idea for today. The thalamus is the terminal for sensation. Every sensory signal from your body, pain, temperature, touch, vibration, proprioception, all of it stops at the thalamus before going up to the cortex. Vision relays through it, and we learnt about that with the lateral genicular nucleus when we did the visual pathways. There's also a great deal of motor pathways that make their way through the thalamus, as well as memory, personality, behavior. Everything to do with the cortex comes through the thalamus. It is the great hub. So let's start with sensation, because this is one of the main transit sections of the thalamus. So let's start by seeing how sensation actually gets to the thalamus and where it goes from there, because this is incredibly helpful for localization. So I'm going to do another drawing here. And what we're going to do is we're going to have our cortex at the top here. We're going to have our thalamus over here. And then a bit lower down, we're going to have our brainstem. Remember, your brainstem is cut into three parts: the midbrain, the pons, and the medulla. Let's just label this thalamus. We'll label this cortex. And then as we come further down, we have our spinal cord. Now, when you feel something in your hand, there's two completely different sensory systems that carry that information up to your brain, and they take two completely different routes. The first are the spinothalamic tracts, and these carry pain, temperature, and crude touch. So spine to thalamus, spinothalamic, that's the journey. So we're going to do that in yellow here. And we're going to have, let's just put a hand out here. So this is your hand and this is your arm. And the yellow fibers are going to be our spinothalamic tracts. Spine to thalamic. So the spinothalamic fibers come into the spinal cord and they cross almost immediately 1 to 2 levels above their entry. So they cross pretty quickly, and then they travel up the opposite side of the spinal cord, the opposite side of the brainstem, and they make their way to the thalamus. Now let's use green for our dorsal column. So the second system is the dorsal column. This carries proprioception, where our joints are and limbs are in space, vibration, and fine discriminative touch. It comes in on the same nerve, but when it enters the spinal cord, it stays on the same side. It goes to the back of the spinal cord, the dorsal column, which is where it gets its name, and it makes its way up to the medulla, and then it crosses over in the medulla. It decussates, and it makes its way up the brainstem and to the thalamus. Now, in the brainstem, we'll go into this in more detail. Thalamic tracts stay on the lateral aspect, and the dorsal column stay on the medial aspect. So they're not joined together at this stage, and they are still separate. So we have two sensory systems taking two completely different paths through the spinal cord and brainstem. One crosses low in the spinal cord, the spinothalamic tract, and one crosses high, the dorsal column in the medulla. And for most of the journey, they're nowhere near each other. And here's where it matters, because they both arrive at the thalamus, the relay station, bringing them back together. And think about it as one train coming in from one side of the country, the other train coming in from the other side of the country. Everyone dismounts at the thalamus and they join a single train that then takes all the passengers up to the final destination, which is the primary sensory cortex. So let's pick a different color here for the primary sensory cortex, like red. All the passengers dismount and they make their way up to the primary sensory cortex. Now, we remember that the primary sensory cortex lives in the parietal lobe in the post-central gyrus, which is what we learned about in our prior episodes. Now, why does this matter for localization? And that's because if the patient has lost pain, temperature, vibration, and position sense, all on the same side of the body, all together, arm, face, and leg, then the lesion has to be in the thalamus or higher. Nowhere lower down do both the systems come together at the same side or run in the exact same location. They're always running in different places. We'll go into more detail when we do the brainstem, but you'd have to knock out a huge part of the brainstem to get a pure syndrome like that, and it would be very unlikely without getting other cranial nerve signs and symptoms. And so right arm, face, and leg, pure sensory loss, you think thalamus. Right here. So the classic thalamic syndrome is a pure hemisensory loss. Face, arm, and leg for the entire opposite half of the body. All sensation gone, no weakness, no language problem, no neglect, just a clean loss of feeling down one side. So when you think that, you think thalamus. Now compare that to last episode, the internal capsule. And if you remember the internal capsule, and it's the posterior limb of the internal capsule, just sits anterior to the thalamus. And in that situation, you get a dense motor weakness with no cortical signs. Now, the thalamus is the mirror image. It's pure sensory loss with no cortical signs. And so you can use both of those to help you localize to very exact locations within the central nervous system. So here, I'm going to say internal capsule, pure motor, no cortical. And here, I'm going to say thalamus, pure sensory. If you're finding this useful, subscribe now because it's only going to get sharper from here. Now, the thalamus is not just sensation. There are actually about 25 to 30 subdivisions and nuclei within the thalamus. So think of that like a train station with 25 platforms. Crazy big, but you don't need to know all of these, just the main ones. And we can do that by dividing it up in an easy way to remember. So if we were to draw an X just in the thalamus like that, then we could label this anterior thalamus, lateral thalamus, posterior thalamus, and medial thalamus. Now, each region of these thalamus are pointing to a certain direction. So we have our anterior pointing to our kind of frontal and temporal regions. We have our lateral pointing to our frontal and parietal regions. We have our posterior pointing to our occipital region, and then we have our medial, which is actually pointing to our brainstem. So if I was to draw where the brainstem would live right here. So all of these internal capsule fibers are going to make their way down into the brainstem, and remember they turn into different names, go down to the crus cerebri, basis pontis, etc. So those fibers are going to come down to the brainstem. And the brainstem, and specifically the midbrain, is very close to the medial aspect here. So when you think of the way they're facing, think about what jobs they're supposed to do. And that's based on the cortex or the region they're pointing towards. So the anterior nuclei are involved with language and memory. And that's because the anterior is pointing towards here, which is kind of Broca's and the temporal region. So there's Broca's and Wernicke's here. There's going to be a little bit more of memory because the hippocampus is involved here. Temporal, frontal, remember that? The lateral region here is actually pointing to the primary motor cortex and the primary sensory cortex. So it's going to deal with sensory and motor functions. And so that's the part that's doing the hemisensory work we just talked about. The medial aspects pointing towards the brainstem, and specifically the midbrain. We'll go over this in more detail in the future, but this is really important for what we call the reticular activating system, a part of the brain that's involved in consciousness and awareness and arousal. And so if you think of the medial aspects of the brainstem, this is critically important for arousal and memory. And then finally, the posterior aspect, which we sometimes call the pulvinar, which is involved in the aspects of the occipital lobe, so vision is important here. And this is very close to where the lateral geniculate nucleus is when we get vision coming in from our eyes through the visual pathways back to the occipital lobe. So you can see the thalamus here is this really great and big relay station that we can break down into 4 major regions: anterior, lateral, medial, and posterior, and depending on which way they're facing is dependent on what they actually do. But this is why the thalamus is the great mimic, because it relies on signals from all over the cortex. A thalamic lesions can sometimes look like a cortical lesion. It can produce something that resembles an aphasia. It can produce visual problems. It can change someone's level of consciousness. The thalamus is wired to so much that when it goes down, it can imitate damage almost anywhere above it. So remember one of our rules of localization: if the light bulb is not working, it could be a problem with the light bulb or the wiring to the light bulb. So if you get cortical signs, the lesion could be in the cortex, but the thalamus, which is carrying the wiring, could be where the lesion is, mimicking the cortical signs. Always start with the light bulb, but if it doesn't work, then go back to the actual wiring. Now let's go back to our case. The woman that's eating breakfast, she's 35, and while she's eating, suddenly, bang, she becomes profoundly drowsy, acute, slumped, hard to wake. She gets to the hospital, she gets an urgent MRI brain, and she has a small thalamic stroke. And on the other side, she's got an old one, a previous thalamic stroke that's healed. So 2 thalamic lesions. So why is she so drowsy? And that's because she's knocked off the medial aspects of her thalamic nuclei, which maintain arousal. You knock them out, especially both sides, and consciousness drops. And bilateral thalamic damage can make a patient profoundly difficult to rouse. And that is specifically the medial nuclei that's failing. Now, this is the interesting part of the story. Over the following days, something else emerges. Her personality changes. She begins talking like a child. In baby talk, a family brings in soft toys, everything turns to pink, and when you ask her what she does for work in a baby voice, she says, "Well, I'm in corporate law." She's a high-flying corporate job. Her brother takes one look at her and says, "This is not her. Who is this person?" And what's happened is she's developed a frontal syndrome. Remember, frontal lobe is to do with personality, inhibition, and disinhibition. And the thalamus, the anterior aspect of her thalamus has been damaged, and so she's mimicking a frontal lobe cortical sign of personality and disinhibition being gone. So it's the great mimic. First imitating a midbrain lesion, and now imitating a frontal lesion as well. So this is one small structure deep in the middle of the brain, and it produces drowsiness. It produces personality changes. It can do motor weakness. It can also do sensory weakness. It just depends on which part of the thalamus you knock out. And the reason we focused on sensation today, because pure sensory loss is a classic thalamic stroke syndrome. Before we finish, I want to leave you with something to work out yourself, and I want you to put your answer in the comments. So here's the case. A patient has lost pain and temperature on the entire side of their body, face, arm, and leg, but their vibration and proprioception are completely intact. Just pain and temperature gone, nothing else. Now, question to you, is that a thalamic lesion or is it not? And if it is not, where is it and why? Think about the 2 routes we talk about today and where they run, and tell me in your answer below, and tell me your reasoning, because the reasoning is the whole point. Now, next week, we stay deep, sitting right next to the thalamus. We move to a structure that doesn't carry sensation, doesn't carry movement, but instead it shapes movement. It smooths, it scales, it decides how much and how little to give. Damage it in one way and the patient freezes up, gets slow, stiff, unable to start. Damage it another way and they can't start moving. They're writhing, they're flinging, they're restless. Same structure, opposite problem. So next week, the basal ganglia. Now, if this has helped you and you feel like you're learning something, subscribe, turn on the bell so you can catch the basal ganglia next week. And if you're new here, go right back to the first episode, start of the series, from the map, because we build everything from there, and you'll feel your localization getting sharper and sharper with each episode. So send this to someone in your year level who's still trying to memorize syndromes instead of understanding them. See you next week.